Good day, my name is Carla Resendiz and I will present the paper Conceptualizing Future-Proof Home. As a brief overview, this research aims to build a framework to conceptualize a house able to support its users' well-being through time in remote settings. In this paper, we present an analysis of older adults' experiences and needs in the north of Scotland. As an introduction, I would like to talk about the population shift. The WHO projected that by the end of this year, there will be more people over 60 than young children worldwide. For the United Kingdom, the number of households headed by someone aged 65 or more is projected to be almost 10 million in 2043, increasing by 54 the 6 million of 2016. Zooming in Scotland, last year the government reported the largest increase in the population group of 75 years old, which increased 31%, while on the other side the population aged 0 to 15 decreased 8%. Specifically for the north of Scotland, most of the area is considered as remote rural, as you can see in the map on the left. The Highlands area has the seventh biggest population and the lowest population density. It is described as the most remote and sparsely populated part of the UK, having as a consequence being isolated from various provisions such as healthcare. The healthy life expectancy, or HLE, refers to the number of years a person will enjoy of good health. The gap between the life expectancy and healthy life expectancy is getting bigger, and the HLE projection for Scottish people shows that males can expect 62 years of good health of 77, and females can expect 62.6 of 81 years. This gap is about 15 years for men and 20 years for women. So managing this gap in remote scenarios like the ones you can see in the images can be challenging. The study Scotland's well-being shows a perception of the quality of public services such as transport and health has been decreasing in rural areas. The strategy for housing Scotland's older people requires housing to be accessible and adaptable and meet their needs, considering the lack of availability of suitable housing for older people in remote and rural areas. The document remarks on the importance of new build to meet the needs of this aging population. Housing deficiencies can affect residents' health. Some consequences in older users are reduced mobility, depression, chronic and acute illness, falls, and social isolation. For this research, we define well-being according to the model Successful Aging and Well-being from Dodge et al. And Rowe and Kahn, searching for a balance between the resources and challenges of older people in psychological, social, and physical levels, lowering the risk of disease, maintaining high mental and physical function, and a continued engagement with life. Also, we consider the WHO definition for healthy aging, which considers the functional ability and maintaining it despite of the presence of one or more diseases. Literature considers different aspects for future-proof housing, such as including care-ready features in houses, integrating new home technologies, uh, allowing people to have an independent living, allowing them to keep healthy and reducing the needs of social care, and knowing that most of the people don't want to move home as a consequence of getting older. So we found the research opportunity for us to develop our understanding on housing design and to explore the impact on aging in place in more remote areas. So the methods we used was systematic review, data collection, qualitative data analysis, and report of insights. For the literature review, we found different documents to use as a guide for the next steps on the research. I would like to highlight the M4 documents for the building regulations in the part 2 and the lifetime homes. We used convenient sampling for data collection, approaching already established institutions and groups, such as care homes, caregivers, and community groups. 25 participants took part with an informed consent. The average age of the group was 68.9 years old, 13 female and 12 men. 90% are already retired. They self-rated their health with 2.8, from 4 being excellent and 1 being poor. 6 participants consider that their activities for daily living are limited by a health condition, and 13 of them share the house with their couple, and the rest live by themselves. So we started with a participatory observation in care homes. After 2 months of this participatory observation, some insights are that the food, drink, and medication reminders are set and managed by the staff. The thermal comfort in public areas of the residents can vary. Use of heating and additional warming with blankets. Chairs, walking aids, and wheelchairs are common amongst the users. Fire doors make it difficult to access different zones of the residence. However, space dimensions and doors allow the use of mobility aid devices. Um, we also executed 2 focus groups with community groups. The goal was to understand their experience and their priorities at home. Some of the things mentioned of the group were keeping the house warm and well maintained. It is important, but it involves high costs. The participants see health deterioration as a future concern, but they keep their checkups on time and they keep as active as possible. Participants are part of the community group to maintain physical and social activity, and they also do other physical activities such as and use step counters. The hobbies and contact with nature are essential for them, as well as contact with family and friends. They prefer physical contact over virtual connections. And loneliness was mentioned several times and as a generalized feeling by the individuals living by themselves. Um, for the case studies, one of the participants of the case study is a user of a care at home service, and the other participant is a member of one of the community groups. Both of them are still independent for most of the day-to-day activities, needing only occasionally support from caregivers. For these studies, we analyze a day in the life of each participant, evaluating each activity, enablers, and detractors they found at home. This evaluation was made using a journey map format with a range from 3 to -3, being 3 the most positive experience and -3 the most challenging. Some insights from these case studies are the use of extra chair and seats and adaptations of cupboards to reach upper areas and to rest when they are tired, use of furniture as a grab rail while moving inside the house, and afraid of falling down the stairs, using reminders to take medication, and using mobility aids when needed to move for longer distances. So the conclusions for this research are due to the extensive stakeholder group formation and setup of the research, there was a high level of awareness and involvement of both of the local communities and caregivers. Other projects concerning vulnerable users in non-urban settings point that the participants' social, cultural, and financial capacities are context-specific and might differ with other communities or contexts. This research is expected to have a positive impact in the remote areas of Scotland and to open the possibility to be the base of the design process for elderly villages in rural settings. The projected population changes might mean that the researchers expect increasing demand from housing associations and developers seeking to provide future-proof dwellings. The next steps for this research are to follow the product development process. Using the human-centered design approach, we will produce the 3D modeling for the proposals for the future-proof house designs and develop virtual reality simulations to then validate the designs with users with a quantitative analysis. We expect to start the validation process on January next year. I would like to mention as well that this project is part of a KTP partnership between Teesside University and Northcote Joinery, and it's supported by Innovate UK. Thank you very much for your attention, and if you have any questions or comments, please contact me via email or LinkedIn. Thank you very much.